Hi, everyone. If you're just joining, you can put your name, organization, and pronouns in the chat. We'll get started in just a few moments. I'm so sorry for my sniffling. The allergies are horrible here.
We're getting a lot of the smog from Canada, Elena?
Horrible.
Oh, geez.
Yeah. Okay. I'm going to keep admitting people because I know people start joining right at the lunch hour here. But thank you all for joining us for our June coaching call. We're really excited for the presentation we have prepared for you today. We have the Stader Opioid Consultants group here who will be presenting to you all. Sorry, I'm a little disorganized with my adding people to the group.
I'm sorry, really quick. I'm just trying to get on some of our team.
Yeah.
I'm just trying to email them the link, but so far I'm struggling. So just.
Yes, I won't start too much until
okay.
people are joining. Yeah.
Thank you.
Yeah, I'll give it a few seconds. There's definitely a rush right now. Yeah, if you're just joining all of us, if you could put your name, pronouns, and where you work in the chat, and we'll get started in just a few moments. Okay, well, I'm going to get started. And Kristen, at the beginning, I'm just presenting a little bit on data, and then we're going to move into Dawn and Rachel's presentation. So they should have a few minutes before that. But just looking at our agenda for the day, we're going to quick start with a few announcements. I'm going to then go into talking about our current state and the data. Then Dr. Stader and Rachel are going to present, and then we're going to end it out with Amber, our QI coach, really talking about how we can implement this during PDSA cycles. So before we all begin, I wanted to make a quick announcement that I have accepted a position in Vermont, which is where I live. So I will be leaving CPCQC on June 23rd. But I wanted to tell you all as in person as possible because this group is near and dear to my heart. And I want you all to know that we have a transition plan. Starting Monday, we actually have a new program coordinator starting, and our data is going to be taken over by Gretchen, who's already been working really closely with us on our data. So not to worry, but I am very sad that I'll be leaving you all because I love this program and I love working with you all. So if you have any questions or concerns, feel free to email us. But it was a pleasure working with all of you. So after that mic drop, I'm going to start talking about our current datascape. But first, we also have an upcoming presentation by March of Dimes that's coming up on June 29th. So if you're interested, you're welcome to scan this code, but we'll also be sending it out via our email list, and it will also go out on social media. So don't worry too much about registering right now, but it should be a really interesting discussion that March of Dimes is hosting. Okay, so hopefully I'll get through all these Okay, so current state, if we're looking at the past year, so from Q2 2022 to Q1 2023, you all have screened 272 patients who screened positive for substance use during pregnancy. And if we look down at kind of what you did for those patients, 77% of those received a social work consult, 23.2% of those had a postpartum visit scheduled during admission, 56.3% were counseled on recovery treatment services, and then 59.5% of those patients received or referred to recovery treatment services. And below you can see the breakdown. If we then look at naloxone distribution, and you all have the option of partnering with Colorado Naloxone Project. So not all of our participating hospitals participate in this program, but of those 272 patients, 26 of those patients were counseled in naloxone, so 9.6%. 23% patients were prescribed naloxone, and 22 patients went home with naloxone in their hand. And then if we look at opioid use during pregnancy, out of those 272 patients, 41 or 15% screened positive for opioid use. And of those 41 patients, 28 of those patients received complete appropriate care. So they received counseling on medications for opioid use disorder, and then inpatient, they either received or they were referred to medications for opioid use disorder. So you all are doing great work, but we're having Dr. Stader and Rachel come and present to you to see how we can really push the envelope on this to really improve the patient care for those with opioid use disorder and dispensing of naloxone. So I'm going to pass it over to Rachael Duncan and Dr. Dawn Stader, who are part of the Stader Opioid Consultants, who are going to talk to you more about these really important topics.
Awesome, thank you. And I am so bummed you will be leaving, but good luck. You'll be doing great work in Vermont. And we're still not opposed to having our next in-person work days with you in Vermont, Alina. So you might not totally be off the hook. But thanks for having us here today. Dawn and I are going to spend the next about 30 minutes going through mostly case-based work to just get you all a little bit more comfortable with medication for opioid use disorder. And it's not to neglect the other substance use disorders. We actually know that in pregnancy, we have much more harmful substances that are used, right? So alcohol and nicotine are by far the most harmful substances that a pregnant person can be using. And so we definitely don't want to neglect that. I think the unique thing about opioids here is really that they are lethal, right? And so what can be therapeutic in one patient can be a lethal dose in another. And so that's really what is driving maternal mortality when you look around both Colorado as well as the nation. It is the #1 cause of pregnancy associated and that year after pregnancy associated death, along with suicide, is accidental overdose. And so that's really why we have this specific focus, because we have to start keeping moms alive, right? And then we can kind of go from there. But one of the biggest barriers that we start seeing when it comes to this type of work, and many of you are really in the trenches and doing this tough type of work, is certainly stigma. And I think that just continues to be the case because unfortunately, rather than seeing this as a chronic treatable disease state, just like you would any other disease state like diabetes or heart failure, because it involves the brain and it involves possibly causing harm to others, right? Some of these habits. I think that it gets this unfortunate stigma associated with it. And that is really preventing those that are pregnant and postpartum from accessing care. And not only is it the stigma associated with substance use disorder, which is just standard across the board, whether you're pregnant or not, it's just compounded by when you are pregnant or parenting. As a mom, I can here to tell you, we are held up on this pedestal. And so we really perpetuate additional stigma here around language that we use. And my co-chair of the Moms Initiative and also on our Moms Plus team is Dr. Kaylin Klee. She is really she's on vacation this week, why she's not with us, but really big on language that we use in person-first language. Beliefs about gender roles, we still really associate, of course, pregnancy with the female gender. And so I could talk all day about the issues there. And then attitudes regarding fitness for parenting. And so when you add all of these things up, it really facilitates this punitive rather than a therapeutic approach. And I think this is where we are all very much aligned, is that we need to change this, right? This is preventing women from not only accessing treatment for a very treatable substance use disorder, but it is preventing women from accessing perinatal care, period, especially from our birthing hospitals. And that's something that we're just really passionate about changing. And so this is just really a graphic showing all the different types of stigma that get compounded during pregnancy. And so it's internalized stigma by that pregnant person. It's interpersonal that is shared in some of our biases when it comes to healthcare workers. And then it's institutional, right? The things that are written into our laws surrounding child welfare. And we are fortunate to live in a state like Colorado, where so many folks with Illuminate and Support and all of our colleagues there have done so much work at the regulatory level, really decriminalizing substance use during pregnancy. I mean, in some states, that's a felony, right? And we live in a state where we are trying to have a more therapeutic approach. So we're fortunate there, but all this leads to just increased harm to both the parent and child, and just perpetuation of that cycle. And we need to start breaking that. And I think that's really why we are so passionate about really getting to the root of this and starting to change our language and our thought processes when it comes to frontline healthcare. And so that's really what we wanted to just start out by chatting about today, is that we need to actively be combating this. And I know that through CPCQC, March of Dimes has a great talk coming up on the 29th. I'm so bummed they asked me to speak, but I will be on a flight during that. But please check that out, because I do just think that it is so interesting to see how we can even rewire our own brains, right? And start recognizing how we actually put stigma into everyday practice. But we need to start incorporating things like harm reduction, which we'll chat about today, and treatment, and building these connections with moms and families, because we want the birthing hospital and everything associated with that to be the first place that women go to seek care, especially if they have substance use, rather than avoiding. And so that we want to be the place that builds that connection, offers treatment as standard of care across the board, and gets folks plugged into long-term community recovery. And so the first piece of that, and it's the MOMS initiative that we are so passionate about, is this take-home naloxone concept. And I think that most of the hospitals on the call here, and I think all that are participating in MSUD actually are signed up for the MOMS initiative. If you're not, email me, we'll make sure that you get it. But we're just really passionate about removing all of the barriers about why patients, especially parents, aren't going to the pharmacy to get a naloxone prescription filled. And as a pharmacist, I get super excited anytime we have an antidote to help save lives. You know, that we do have lethal opioids out there, both whether it's prescription or illicit, but we also have an antidote. Nobody needs to die, whether they're using a prescription or illicit opioid. But folks are not running to me in the retail pharmacy to get these prescriptions filled. Fill rates are dismal. And that's really based on, that's rooted in that stigma that we talked about already, right? They might see me in their mom's group on Wednesday or at library time, right? And now I know that maybe they have substance use and it's still highly stigmatized, so they're not coming to me. So we really rely on our frontline healthcare workers in the hospital to be handing this directly to patients. And I think that's where we're really starting to remove some of these barriers, destigmatize it. I always like to tell my patients, you know, I carry naloxone. Here, you know, it's in my bag. I think it's a really responsible thing to do. If you don't carry naloxone, I would challenge you as a healthcare worker, go get your prescription filled. Kaylin will write you a script, Don will write you a script. You can get it over, you can essentially get it as a standing order, or we'll send you some, let me know, okay? I think it's a really, really key part to normalizing it in our communities and with our patients. And so again, we just have to start removing some of these barriers, which are deeply rooted in stigma. And that's what we wanted to start out talking about today, is just really optimizing some of those naloxone stats that Elena kind of presented at the beginning there. We really want all of our hospitals that are involved in MSUD, as well as those Moms Plus hospitals, to really be high performers when it comes to getting naloxone out the door through our OB units. So please reach out to us if there's anything we can do to support your frontline staff and getting them some of this messaging and training. We want to make sure that we're getting it into the hands of at-risk patients. After that brief introduction, we're going to dive right into medications for opioid use disorder. Oh, shoot. I just gave away the first polling question, I think. That's okay. Well, all right. You want to pop up that polling question? Aline, we can probably skip through that
Yeah,
one.
hold on.
Spoiler alert, MOUD. Everybody better get this right, okay? All right, so what does MOUD mean? It means medications for opioid use disorder. Oh, look at that, 100%. Yay. That means folks are listening. Strong work, strong work. I got too excited, okay. All right, yes, medications for, yep, we're just gonna keep on rolling. We're gonna dive into our first case, because I don't know about you, but I can blast up all the slides and content you want, but I learn best through kind of real life scenarios. And so we're going to dive right in here and learn it as we go, and just introduce our first patient. So this is Amber. She's 27 weeks pregnant and presents to the hospital for urinary tract infection symptoms. While there, she discloses to you that she is currently using high doses of fentanyl. You offer to help her get her started with treatment, and she's agreeable, which is amazing. She has no acute need for admission. Her UTI can be treated outpatient with antibiotics, and she really prefers to not be admitted, right? She's OBS right now. You really want to be able to send her out. There's no local OTP clinic, so that's like a methadone clinic, okay? Because we know that methadone is, of course, federally regulated. You have to go to specific outpatient treatment providers for that. And so just noting that there. So I'm going to go ahead and go to our second poll question and not give away the answer. So polling question here, can pregnant patients begin medication for OUD at home? So I'll give you a minute to answer that. And kind of see, you think you should bring Amber into the hospital to start that, or you think that's something that is safe for her to be able to start at home, you know, along with that antibiotic for her UTI? All righty. Okay, good deal. So about 90% said, yes, I do think that this patient can begin medication at home. And so I'm gonna, oh, there was an I'm not sure. I'm gonna include Dr. Stader in this conversation as our clinician here today and kind of get his thoughts here. Many of you probably know Dr. Stader. He's the executive director of the Naloxone project and is kind of helping us lead many of our perinatal initiatives throughout the state with CPCQC through our Moms Initiative, Take Home Naloxone, and Moms Plus, which is all focused on treatment in the hospital. And so I just, Don, what do you think? You think it's safe for her to start treatment outpatient, and why?
Yeah. So first of all, these are the types of cases that we get really excited about in addiction medicine. Everyone is on that continuum of pre-contemplative, contemplative, and action. And the fact that she's come and is willing to actually start treatment is really when we have to have a concrete plan to care for this patient. Because if we don't, then oftentimes the patient will go back and to not go into withdrawal, start continuing use. And that, of course, is a clear and imminent risk to both the patient and of course, your baby. 100%, we would love to treat this patient. We can do it as an outpatient. I'd want to know a lot more in why she wants to be an outpatient versus inpatient and what type of resources she has, how she can keep herself safe as she does the transition. So really, there's a lot of other things to consider, but the answer is, heck yeah, we can figure out how to treat you.
Yeah, and there's also some good office-based protocols, like if she doesn't want to be in the hospital to do it, maybe this is someone you'd give the first dose to as an outpatient in the office just to see, because as we'll talk about, there are certainly some nuances when it comes to fentanyl use. But our second question here is, what medication is most appropriate to start the patient on in this scenario? And so we have here our buprenorphine, which is also known by the brand name Suboxone. We have our methadone, which I kind of mentioned already, and we'll chat about that. And then option C is diazepam. And I know Elena put up the polling question there. I'm not sure if folks will let her kind of look at when folks have answered and blast up that answer.
There's still a few more people voting.
Okay, can everyone see that? It looks like about 80% thought buprenorphine. A couple thought methadone. Anyone who mentioned, who answered methadone, willing to either put in the chat, and Don, I'll let you look at the chat because I don't have it pulled up right now, or want to come off mute and maybe say why you think methadone, because I certainly don't disagree with you. Don, you want to weigh in here on what you would choose for Amber?
I would love to have the flexibility to start Amber on either buprenorphine or methadone, but the fact is that without an OTP, we cannot actually treat Amber with methadone in her community. So methadone is extremely strictly, basically federally controlled, and you can only receive methadone treatment and maintenance at an OTP. So while I think it's a really good drug and very useful in someone with fentanyl use disorder, for Amber, sadly, that's not really an option in her treatment plan. So we'll need to really, if she wants to stay in that community and birth in that community, it's going to need to be one of the two other ones, which is buprenorphine or naltrexone. Naltrexone, she's not a good candidate for at all. So really it's just buprenorphine as our agent here to help treat her opioid use disorder.
Yeah. All right, and let's bring this case home here. Our last polling question. What type of buprenorphine start is most appropriate for Amber? And I had this question as how would you do the buprenorphine induction? And Elena said, induction has a much different meaning in this patient population. So buprenorphine start. Thank you for that. I was like, okay. And the choices here are standard. So just starting at a normal buprenorphine dose. B is low dose. So starting at very small doses. And then C is I'm not sure, and that's fine.
So I'm just going to answer so naltrexone requires a lot more abstinence for this patient. So for example, for naltrexone, you should be abstinent from all opioids for around 2 to 3 weeks in order to initiate. And then if, for example, the patient did require opioids during her delivery, had a C-section, etc., it would render those that less effective. Then there's the other consideration is that to really, in terms of evidence, now there's more evidence for buprenorphine and methadone when it comes to outcomes such as return to use and overdose death, etc. So those are considered in a way superior medications for use disorders, at least by many addiction docs. You'll hear some debate over that, but this is a patient who would be very hard to transition to naltrexone. Thank you for the good question, Kitty.
Mm-hmm. And so here's the answer. It looks like we're a little bit split, and I'm not sure is definitely an okay answer. This is fentanyl has changed the game when it comes to how we treat patients. And one reason that we'll chat about, I think a lot of folks think of fentanyl as a very short acting medication, right? So when we use it on the inpatient side, it's IV. We think of it as only having an hour or two of efficacy, right? And then we're redosing there. But when we think about it long-term use, fentanyl is very lipophilic, meaning it gets into the fat cells. And so although it is technically very short acting, it hangs out in the fat cells for days. And so if someone is a consistent user, even if they haven't used fentanyl for 6 or 8 hours, which is what you would typically think to kind of get it out of their system, it's still hanging out in the fats. And so that's where we really start to see issues when it comes to some buprenorphine starts. And so Don, I'm going to throw it back to you and talk about, would you do a standard or a low dose induction with her, and why?
Yeah, so I think that both are considerations. The standard induction means that the patient stops and goes into significant withdrawal before you initiate. And there's risks associated with that because withdrawal can also, of course, cause the patient to potentially have preterm labor, et cetera. So we're a little more cautious about just letting that withdrawal process happen. So the more likely thing would be a cross titration to buprenorphine or a micro titration. Those are oftentimes first for it, where you start very low with buprenorphine and then scale it up over the course of around a week to a full dose. And that usually will help ameliorate some of the withdrawals that the patient has and help transition them more delicately to, you know, I guess more physiologically sensitively to buprenorphine. So low dose would be definitely how I think we think of starting this patient.
Yeah, and one important key piece there is that Amber can continue to use fentanyl throughout that. So the thing about buprenorphine is it's a partial mu agonist, meaning it doesn't completely occupy that receptor like fentanyl would, which is why if we just gave a big dose of buprenorphine, it would throw her into withdrawal immediately. So because buprenorphine has a very high affinity for the opioid receptor, even though it's not completely occupying it as a full agonist. So that's really why we want to start low, have her continue her fentanyl use so that she doesn't go into withdrawal, titrate her buprenorphine up to slowly occupy that receptor and then decrease her fentanyl use. This is certainly where we have protocols that are available. You are not trying to make this up on your own, I promise you. And this would take a fairly savvy patient, okay? And so for someone like this, if it got too confusing, we might bring Amber in, or we might have her do this very closely with an outpatient provider, checking in daily, okay? So don't think we're just leaving her on her own there.
Yeah, and I'd like to speak to that because definitely with fentanyl, I think there's a few more nuanced questions in terms of what her supply is. If she's in a point where she's going to need to go out and buy more and might have pills that have different potency, that's higher risk. I think for a lot of us who are dealing with fentanyl more, our preference with these types of patients might be for an admission to transition over to full agonist and then to do that kind of cross titration, maybe even in the hospital. So these are all different considerations based on the patient's willingness to undergo different treatment and your hospital capacity to potentially admit a patient via OBS or via longer stay for their initiation of buprenorphine.
And here I'm just showing an example of what that cross titration looks like. You can see here we're starting with a very low dose, 1/4 of a film that first day. The second day, you're doing 1/4 of a film twice daily. And then by day 7, you can see that you're up to a full film and an 8 milligram dose, which is kind of like a normal Suboxone dose for especially those with heavier use. And that on that day 7 is when we think that she can likely just stop her fentanyl use. And of course, we want to make sure that she has close follow-up and referral, especially for multiple reasons. She's pregnant, as well as this is a big change, and then hopefully doing a lot of other perinatal care for her as well. All right, and as Don mentioned, another option here is to just bring her in, right? If it's getting too complicated, she's feeling overwhelmed, you're not feeling sure, always err on the side of bringing her in, keeping an eye on her and baby. Although we really know at this point that we don't need to really do fetal monitoring in these types of situations. However, it is, I think, especially if it's your first time trying this type of thing, definitely not a bad idea, depending on comfort level. All right, let's go to our next case here. Oh, actually, we still have one more on Amber. If Amber was already in withdrawal and hadn't used fentanyl in a few days, okay, so few days, how would we change her approach? So we would still begin with the low dose protocol. We could go ahead and start the standard induction, so just start her at the 8 milligram dose that we built up to. We would admit her, or I'm not sure. If she hasn't used in a few days. She'd probably be in pretty significant withdrawal if that were the case. Amber's probably hurting. All right, Don, what would you do?
I think you can consider a standard induction here. And for example, if you're in a clinic and this comes into your clinic, this is the perfect person to call and coordinate with your ER and say, I'd like to send someone into you for basically initiation of treatment. If, like, for example, I was working at Swedish or my other emergency department, I got a call like this is definitely the type of patient that we'd feel comfortable doing their induction, especially if it's been blessed by, let's say, our OB colleagues who think that this is important to initiate, which for all of us, yes, this would be. So if, for example, you're in a hospital, I think you can do that, in the hospital. If you're in a clinic, I'd send them to the ER to get their induction, their initiation done, just so we can get her on the medication while we have this amazing window of opportunity.
And you can see here, there's a couple of recommendations with fentanyl use. Like I mentioned, it's very lipophilic. So we typically want to wait at least 24 hours to usually closer to 36 if they can tolerate the withdrawal to do that standard induction. Whereas if they're using something like classic heroin, which you need to test for fentanyl and make sure there's none in it, because that's a totally different story. You can just wait the kind of standard 12 hours or a short acting opioid. And then they only have to be in withdrawal for a short period of time and then go ahead and start it. So just a very, tricky situation with fentanyl kind of taking over the illicit market at this point. And we have, of course, have protocols. We're not going to go into these in details today. These are all available to you. Let me know if you want to see these. But just kind of talking about whether or not after a dose they're feeling better but still in withdrawal, go ahead and give another dose. If you actually put them into withdrawal because it hasn't been as long as Amber was forthcoming with you about using fentanyl, then there are other things we can do to support her through that. And that's another reason maybe to send her to the ER for that first dose, just to make sure. If you're not familiar with it, many of you are probably familiar with the COWS, which is what we would use on the inpatient side. That's administered by a healthcare professional to a patient to look at opioid withdrawal. This is the SOWS, which is a subjective opiate withdrawal scale that you can send home with patients if they are doing a home induction, where they can do their score based off of subjective symptoms. And once they get into moderate withdrawal, go ahead and start their buprenorphine and help them decide how to go up or down on dosing. And so just wanted to show it to you. It's sometimes difficult to find online, the SOWS scale, I find. All right, let's go to our second case. This is Emily. She's 34 weeks pregnant and presents to L&D. She's having contractions, nausea, vomiting. Don't love 34 weeks, but I guess we can handle that. Upon exam, she's tachycardic and diaphoretic. She informs you that she's been taking oxycodone and hydromorphone throughout her pregnancy, unbeknownst to her provider, but she can no longer access it. That's why she's in withdrawal. She's fearful for her baby and asks about beginning treatment with methadone. So she's coming to you for help. So let's go to our polling question here. Can methadone be initiated in the hospital? All right, Don, can methadone be initiated in the hospital?
Heck yeah, it can.
Yes, good. This is a commonly misunderstood concept, so I'm pleased by this polling that most folks are aware of that. That's great. Do not hesitate to use methadone unless you don't have an OTP to send them to, but yes, absolutely. So our next polling question is, how long do we have to wait after Emily's last opioid use before initiating methadone? So 36 hours, which was about as long as we needed to wait on the buprenorphine with fentanyl use, right? B is 12 hours, C, we don't have to wait. D is, I'm not sure. So she's using oxycodone and hydromorphone. She's in withdrawal. You test, she's not positive for fentanyl. So you'd always want to test for that. Of course, that would change, it wouldn't change this piece, but just always want to know. And how long do you have to wait before initiating methadone? You want to put up that answer, Elena? And Don, how long would you wait?
You don't have to wait with methadone, which is one of the biggest benefits of it when it comes to fentanyl use disorders in particular, is the transition from, from fentanyl to buprenorphine can be a little bit trickier just because of the long half-life. But methadone, you can really begin as long as the patient's not sedated, intoxicated, etc. It's a much easier transition to methadone for patients with opioid use disorder.
And the reason being there is that methadone is a full opioid agonist. So although it's going to knock the fentanyl, in her, the oxycodone, whatever remaining oxycodone hydromorphone might be hanging around, it's going to fully occupy the opioid receptor and not put her into withdrawal. Okay. And that would be the case for fentanyl use as well. So that's really, I think, why methadone honestly is making such a comeback at this point. I think we kind of all got on the Suboxone bandwagon because it was less regulated, easier to use. But with, if she, like with Amber, the first scenario, methadone really would have been more ideal for her if she'd had access to an OTP. But just showing you an example of how you could do a methadone titration on the inpatient side, kind of starting day one with that 30 milligram standard dose. The thing about methadone, you have to be a little bit careful because as you're starting it, eventually doses will kind of stack up and you will saturate those receptors. And so there is this always fear or just needing to be careful not to overdo it. But that's why we do this more slow inpatient titration typically. If that 30 milligrams were not completely covering her and she was still in withdrawal, Don, what else could you offer her? You don't want to stack a bunch of methadone on day one, right? You don't know how she's going to react to it. And maybe that's this question. Hold on, let's see. Oh, no, it's not. So what else could you offer her besides the methadone?
Yeah, and I think we'll get to this, but you can offer her non-narcotic things to help control her withdrawal. So things like clonidine and Zofran and other things to kind of help with that. And then the other thing, though, is full agonists. You can offer, you can give, other opioids to meet the patient's opioid requirements. So in everyone, right, once you have dependency, your dependency can be really, really significant in how many MMEs you need. And if you're not there with methadone as you're scaling it up, the answer is to fill the rest of that opioid requirement with shorter acting opioids, like for example, morphine, Dilaudid, etc. Again, you want to make sure the patient is out of withdrawal while you're scaling up the methadone to what the patient actually needs.
And I think that's one of the most commonly misunderstood or misapplied things is I think that even early on in my practice, and I worked in ICUs a lot, and it was let these patients go into withdrawal. They came in over sedated. They had to be on naloxone, things like that. Like, why would I go ahead and turn around and give them opioids? And it's a completely wrong frame of mind. You're not doing Amber or Emily any favors by putting them into withdrawal. It is perfectly acceptable to give a full opioid agonist to keep them out of that as you're transitioning them onto treatment. It's really doing them and their baby a disservice to going into withdrawal. There's danger there for going into preterm labor. And so really any patient, whether pregnant or not, our goal is for them not, to be in withdrawal, keep them comfortable. We want to make them as successful as possible in that transition over to treatment.
And I would love to just chime in here and just also, Rachel, just for our purposes, we have 5 minutes. So we might want to basically use this as our last case. But with this, I think too, I've often heard people tell me this, we don't want to feed their addiction, right? And if we give them opioids, then we're just feeding their addiction, and almost like a stray dog or stray cat, they're going to start coming back to the hospital. And that's really the wrong frame of mind. Remember, addiction is two things. It's an opioid dependency, and it's behaviors that are self-destructive or that are driven by a lot of the things we don't like about addiction. And really, by addressing that dependency, you give patients the space to make decisions that are in the best interest of their overall health and in the best interest of others in their, in their family, community, etc. And that's actually the cure to addiction, is actually to answer that dependency issue, which this patient obviously has, and then give space for that patient to return to normal functioning in the other aspects of her life. So here, really, full agonist therapy to get her to a place where she's not in withdrawal is how we really start transitioning that patient into recovery, a medically assisted recovery.
And the other piece here that feeds directly into this polling question is that both methadone and buprenorphine are safe in pregnancy and breastfeeding. And I know I kind of alluded to this before, the most harmful substances in pregnancy are not actually opioids, right? It's alcohol and it's nicotine. However, using illicit fentanyl and doing big peaks and valleys, putting folks the withdrawal in between doses, that is harmful. And some of the behaviors there can be harmful, as well as that risk of overdose is of course harmful to mom and baby. And so I think there we really, really want to get folks onto a sustained recovery and treatment, both for mom and baby. It's going to be best case scenario there. And so just really, really emphasizing this is validated, evidence-based, safe in pregnancy and breastfeeding, either treatment. Okay. So I guess I kind of gave that question away, but methadone and buprenorphine are safe in pregnancy. And so just really reassure yourself, reassure the clinicians around you, and reassure your patient that this is certainly safe and in what is recommended. And I want to make sure we leave enough time for Amber to go through. So why don't I go ahead and stop there? And I think the only other really thing that we wanted to share today before we send it back is one thing that Caitlin always says, and let's say we do have a patient that comes in and they're pregnant or they're postpartum and they have significant fentanyl use and they're not interested in treatment. And as we would say standard treatment with buprenorphine or methadone. At that point, what is the treatment for that patient? And I'm just going to throw that question out there. What else could you do for that patient and that family? Don's got it. So harm reduction. Harm reduction is treatment for those that are not able, ready, or in a position to get into a formal treatment or long-term recovery, right? We can teach Amber how to maybe inject safely, right? We can give Amber and her family naloxone. We can keep her out of withdrawal. You know, even if we're not starting buprenorphine and methadone, we can use full opioid agonists to keep these moms out of withdrawal while they are there for their admission, whether it's a birthing admission or not, right? That's the last thing we want is folks leaving AMA. We can provide comfort medications. We kind of say withdrawal management. We can give her Dilaudid. I know it sounds against everything that we were all taught, but that we know that is much better than Amber delivering and immediately leaving AMA and leaving a baby and having zero chance of those two reconciling. So that's the last thing I just want to leave with you today. And also making sure they go home on naloxone, of course, and just meeting patients where they are. And I'm going to send it over to Amber now.
The other Amber. I hate to cut off this information because we brought on Don and Rachel because we know it's such valuable information. And we hope to also use this just as a plug for Moms and Moms Plus. There's so much great programming going on around this type of information. If you guys want more information, reach out to us. Also, I wouldn't, if you guys wouldn't mind giving us a thumbs up if you would maybe be interested in an additional lunch and learn session on this type of information where we could just have more of an open Q&A. I know this felt really abridged and there's so much to cover here. And I think the opportunity to ask Don, Rachel, and Kaylin questions directly is super valuable to our teams. And so maybe a little thumbs up in the chat or on your photo. Elena will take note of what you all are doing and let us know what you all need with the knowledge that Moms and Moms Plus also is available through their own channels. So we, at all of our coaching sessions this year, have devoted at least a little bit of time to quality improvement. I always like to sort of preface this, Elena, next slide, by just reviewing why we're here, that SUD is at its heart a quality improvement program. The reasons that we're here, which we started, Rachel's discussion with, is that suicide and unintended drug overdose are the leading causes. And because these are non-obstetrical causes of maternal mortality, I think it's really in particular important that we focus extra effort on making sure that we're giving evidence-based care for those of us who live solely in the obstetrical realm and have relatively little background training on addiction medicine. So Of course, that's the background of why we're here. But next slide, Elena, is, we always bring this back to the model for improvement and how it is that we actually go about improving the care that we're giving with some evidence-based steps. We've done this in previous sessions. This is a review for you all of how we've kind of really just stepwise gone through these first key questions when we're talking about quality improvement. And that's addressing what it is we're trying to accomplish. We dedicated an entire session on developing aim statements, how you all can do that effectively. We devoted another section on answering this third question here, which is what changes can we make that will result in improvements? We have recorded sessions on using the 5 whys tool, cause and effect diagrams, driver diagrams. Please go back and review those. These are also topics that we cover in our one-on-one sessions with our teams. So Lena, I'll have you go to the next slide. I wanted to just kind of quickly throw up here for you guys the driver diagram that we talked about last month, because it feeds into the things that I want to talk about today, which is using the change ideas that we brainstormed on the right-hand column here. And now that we have those ideas of how to impact our particular facilities and our particular practice sites, how do we actually use those ideas in practice? How is it that we change the practices that are happening in our facility for the positive? So next slide, Elena. Stepwise going through this, what we would ideally do next is talk about measures, how it is that we're going to measure the improvement that we're moving forward with. But because the topics that we covered today are so timely, and the information that Elena led with this morning, which is that our screening rates in our cohort are excellent. Our facilities are doing a great job about doing universal screening for substance use on admission to the birth facility. What we're not doing excellent yet is the clinical care practices that need to happen for positive screens. And Elena shared those stats with you. Only about 1 in 3 patients who screen positive for substance use are having a postpartum follow-up scheduled prior to leaving the hospital. This is an important gap that we have a role in filling. And then of course, all of the stats on the fact that we're not counseling everyone. We're not referring everyone to treatment. We're not distributing naloxone effectively as we could. So for that reason, rather than doing a talk on measures, which we're going to defer until next month, we're going to jump right into the plan, do, study, act cycles, because I want us to immediately follow up the talk that we just did with, well, what do we do about it now? Right? We know this evidence-based information. We know that care is available for the patients we're identifying. How do we actually implement that care into practice? So Elena, next slide. And we do that through plan, do, study, act cycles. And I know that you all hear us throw around this word all the time. We say, what's your next PDSA cycle? Or what did you do for a PDSA cycle? And I wanted to sort of demystify it a little bit here for you. And that's just to just say, PDSA cycles are just small tests of change. It's you all taking your change ideas and experimenting with them on your unit, starting on a very small scale and then working up as you see what's working well for your staff and what's improving your outcomes. They're typically really rapid cycles of change. They can last for a day, they can last for a week, they can last for a month, but it's starting somewhere with your change ideas and seeing what sticks. So Elena, we'll go to the next slide. I wanted to just talk through a couple of really brief examples of what a PDSA cycle could look like at your facility. These could be transferred to really any of your change ideas, but I think it's really valuable for you to see what exactly is it that we mean when we're saying, are you testing your changes and are you doing PDSA cycles? And one of those could be introducing a new protocol to your unit. So like we identified in the first couple of slides here, many of our patients are not getting postpartum visits scheduled prior to leaving the facilities. So one facility might put this PDSA into action, which is they plan to modify their unit's discharge checklist or their protocol for their nurses and add scheduling a postpartum visit to the discharge checklist so that we ensure that it's completed prior to the patient leaving the hospital. That's the plan. What the nurses on this unit actually do is that they have the discharge nurses use this new checklist that includes scheduling a postpartum visit for 1 day shift. Ideally, they would do it whenever you're well staffed and when you, as the leader of your quality improvement program, are there on site to answer questions. But just 1 shift, let's walk through that and see what does that look like. And then after you do that for 1 shift, at the end of the day, huddle, do a quick huddle with your team and say, hey, for the nurses who did a discharge today, what worked well? Were you able to schedule those postpartum visits? If you weren't able to schedule them, why is it? What extra tools do you need? What extra protocols do we need in place in order to make that happen? And then once you've done that information, you need to decide what you're going to do about it. And that's the act at the bottom here. You and your team need to decide, did this protocol work? Are we going to adopt this protocol? Let's try it for a month and see how it goes. Or did it work, but the nurses gave you some excellent feedback that it would be better if this was done prior to discharge rather than right at discharge, right? Adapt how your protocol works and then try it again for another shift and see how that goes and get your nurses to give you feedback. Or did this not work at all? Maybe your nurse had said, we couldn't get a hold of the clinics. We have no idea how to schedule postpartum visits. We are not the people to do this. We don't have the time and the resources. Then your team needs to abandon that idea and do another change idea and see what needs to happen next. So now, Elena, we can go to the next slide, which the other PDSA cycle that's really common for our sites right now is for the staff saying, okay, I have a positive screen. I did my screening tool just as you told me to. And now that I have that positive screen, I don't really know what to do. I feel really uncomfortable addressing a positive screening tool with the patient that's in front of me. And a really great anecdote to that is to do a trial PDSA cycle with scripting for your staff. Give them the exact words that they can use whenever they're addressing positive screens with patients. So a PDSA for this could look like, why don't you plan to just choose a script? We have scripts available. Our Moms Plus program has given us excellent scripts that we are happy to distribute. In fact, Rachel has recorded a video on scripting and language around positive screens. We're happy to make all of these resources available. Choose one of those. Choose the script, choose Rachel's video, and distribute it to your staff. Right? Just let them see it, put it up on the unit. And then at your next staff meeting, your due here can be to play out a script during your staff meeting, right? Get an adventurous or a dramatic nurse and you and her play out a script. Let her be the patient or let her be the nurse and walk through what that conversation looks like to model it for your nurses. After that staff meeting, ask your nurses, was this helpful for you? Do you want more training on this? Would it be more valuable if you actually practice scripting with me directly? Get their feedback on what was or wasn't helpful about that, and then act upon that feedback. Maybe the nurses say, okay, this was really helpful, but why don't we do this training with the providers, right? That's a really valuable piece of feedback. So now you can do a PDSA cycle doing this scripting with your provider staff. So again, simple, it's fast. This is 10 minutes of one of your staff meetings, you getting really valuable information on how to empower your nurses to have the language that they need in order to handle a positive substance use screen. And then finally, we'll go, I have an example here on the next slide, Elena, of this is just a snapshot of what some of that suggested scripting from the Moms Initiative looks like. Ask us, we will probably include it in our follow-up email. If you want more information about this, Rachel is an excellent resource about it. Finally, the last PDSA cycle that I wanted to give you as an example is how to handle a positive opioid screen. And as Rachel identified, we do pay extra particular attention to these, and not because we think it's the most important substance to identify, but we do know that this one is most closely associated with mortality issues. And so for that reason, I really think that we need to shift our mindset as clinicians and consider the identification of a positive opioid screen as a high acuity, low occurrence event, right? It's not every single day that we identify a positive opioid screen, but we know when we do identify it, that is our opportunity to save a life. And this is true of managing hypertension, managing sepsis, managing hemorrhage. And what do we do for those events? We do drills, right? We do monthly, quarterly, yearly drills. We do multidisciplinary drills in order to know how to handle those. So I know I see Don and Rachel saying, like, why are we doing this? I agree, we should be doing this. So an excellent PDSA cycle for this on your unit would be to plan a trial skills drill, right? Come up with a scenario of a nurse identifying a positive opioid use screen, and then trial that skills drill with maybe just your charge nurses, right? At your next charge nurse huddle or monthly meeting, trial that skills drill with your charge nurses and see how they react. Are they able to come up with all of the right clinical care practices that they need for managing a positive opioid screen? If they aren't, guess what? Your staff nurses aren't either, right? And so get feedback from this small subset of nurses going through a case study or a skills drill on how they would manage that, and get their feedback of what's missing on our unit. right? Maybe the nurses don't actually have the physical equipment that they need in order to be able to handle a positive opioid screen. They don't know how to get them naloxone. They don't know actually the process for scheduling a postpartum visit. They don't know how to get the social worker in the room on the weekend, right? These are the things that you can troubleshoot through a skills drill. And then once you've done that with your charge nurses or your small set of nursing team, get their feedback and then do it on a larger scale, right? Then do it on your next monthly skills drill. If that works really well, do it on the quarterly multidisciplinary skills drill, right? That you can scale this and then embed it into your yearly skills drills, right? Again, we do this all the time with clinical things that can kill patients. There's no reason that we shouldn't be doing it with opioid. I'll step off my soapbox for a quick second. The last slide here is that I have just three little pieces of advice for PDSA cycles. And I've covered a couple of these things already. One is that once you have a plan, and especially a plan that you feel really passionately about, as you can tell I feel about using skills drills for positive opioid screens, our inclination is to go big, right? Our unit could benefit from this. Let's throw it in and do it, right? And really, I would caution you to go small first, right? If you feel strongly about it, do it for a day, see how it goes and get information. If it works well for a day, do it for a week. If it works well, do it for a month, right? So scale down and learn from each step. That way, when you're ready to roll it out big picture, you've worked out all of the kinks and you're giving a really high quality product to your entire facility. My second one is to track your cycles. It's really easy when you're doing these tiny little tests of change to forget what you did and what you learned from it. Doesn't have to be formal. Get a Google spreadsheet, get a notebook that you keep in your nurse's station, and just say, hey, in May, we did this PDSA cycle. This is what we learned. In June, we did this. This is what we learned, because it's really easy to forget these things. And then finally, share your progress. The nurses on your unit, the providers on your unit, they want to know why you're doing these little experiments. Keep them updated. Keep a whiteboard, put up a sheet in the nurse's station once a month just to say, these are the PDSA cycles we did. What's your feedback? Or this is what we're planning to do this coming month. This is, what's your feedback? Keeping them keyed in is really important to engaging them and to improving care. So finally, I cannot end a QI talk without throwing up this last slide, which is that within our team, our huge goal for this year is to make sure every single facility has a multidisciplinary work group to support this work. There's no reason that a nurse manager should be doing this alone. There's absolutely no reason that a data champion should be alone in this. We should have social workers, infant care teams, addiction medicine specialists, ER physicians, inpatient and outpatient providers putting all of our collective knowledge together in order to address this. So we have tools that are available if you don't already have a multidisciplinary work group to help you build one. If you need any support to us, we've set a pretty low bar goal, in my opinion. We want 30% of our teams to have these multidisciplinary work groups up and running and active by the end of the year. I would love to see that be 80, 90, 100%. So if you need resources, tell us, let us know. And unfortunately, we aren't. We are out of time for Q&A, but I hope that some of you gave Elena a thumbs up or some comments here in the box to let us know if this is interesting. Do you want a Q&A session, a short lunch and learn? We'd be happy to facilitate that and get you answers to the questions that you have. Whew, that was fast and furious, Elena. I'll let you wrap up.
I was gonna say, like, woo! I feel like I'm on board, this was your campaign. Well, thank you all. I really appreciate this. I'm gonna pop in the survey for you if you want to receive CEs. If you are a social worker and you want your certificate of completion, you can fill out our evaluation survey that's separate from the one in the chat that I'm going to be popping up. And I will send you a certificate. So if you could complete those, that would be awesome. I only saw a few thumbs up, but I don't think that's due to lack of interest. I think that's due to not knowing where the thumbs up button is. So if you're interested, you can throw it in the chat right now, or you can email me. But Rachel and Dr. Stader are available for questions via email in the time being. But again, thank you all for coming. I know we're at time, but we're really appreciative of you coming. And everyone else except me will see you at the July coaching call. Bye, y'all.